treatment, right? Okay, so let's look at this right quick. Asthma is an immune problem. They have something it's sort of like an allergy type of problem. It's an immune system dysfunction. It does cause bronchospasms. That's where you get the constriction from. It's from the bronchospasms. They spasm and they close off. Sort of like we would talk about with angina. A lot of times those coronary arteries will spasm and they will close off. You get the swelling. This is the problem with the edema in the airways, the problem that you guys can't handle as EMTs. That's why they need ALS in hospital care. Most wheezers that go to the hospital, they have their albuterol and they're doing the albuterol. They go to the hospital to get the steroids for the swelling. All right. So a lot of increased mucus production, and the most severe asthma attack is this one, those Latins, status asthmaticus, okay, which means that this patient is having one asthma attack right after another one without any sort of rest. So it's sort of a continuous asthma attack, okay? The same way with status epilepticus. What would that be?
Constant seizures.
Seizure. One seizure after another one without or very little postictal phase. Okay? So this person here, that's sort of status asthmaticus, it is life-threatening. They're not going to be able to breathe very well. So that's a life-threatening emergency. As we look at the picture, this should bring back memories. Okay? Here's a nice bronchial, the muscle layer, the mucus layer. Remember, we always have mucus in the bronchial. All right? Well, when someone has an asthma attack, what takes place is these IgEs, these globulins, I call them. These things form up, and these receptor sites here, they throw these antibodies over here on these receptor sites, and what happens in short, this mast cell, okay, it ruptures this mast cell essentially and releases histamine. So the histamine is what's causing all the problems in essentially in asthma, is the release of this histamine. Now don't get it confused when we talk about allergic reactions, because when we talk about allergic reactions, it's the same process. It's a release of histamine, all right, that causes the problem with allergic reactions. But you can't give the same medication. It's outside of your scope of practice anyway, but you can't give it. It would make sense here in this asthma attack that this patient's having a release of histamine, okay, to give them Benadryl, right, for the allergic reaction. But if you give them Benadryl, the albuterol won't work. They're not compatible together. Okay. I gave that scenario to a paramedic student one time and sent him on his way to figure it out. And it was an all-day event. He was just trying to figure out why you couldn't give Benadryl to an asthmatic, because to block the histamine releases. And I did it on purpose, but it was funny to me and everybody else. But this guy spent all day, I guess, on his phone with Google and trying to figure out why you can't do those things. But the release of this histamine causes this. See, we have this nice open lumen here, bronchial, and now it's all clogged up. A lot more mucus production. The muscle contracts and constricts. So you have swelling, you have mucus production. Okay, so you give the albuterol, which is the beta-2 agonist, right? So it will bronchodilate by relaxing the bronchiole, correct? In all the cases, emphysema, chronic bronchitis, all the cases you would give albuterol. It's going to relax this bronchiole and cause it to dilate. Now, what about the mucus?
You do Atrovent.
Very good. You give the Atrovent, right? You can give, if it's in your protocol, you can give the Atrovent, and the Atrovent will help dry up the secretions. Usually that's the case. You give them both. You put them in the same tub, okay, and then you nebulize both at the same time. It dries the secretions. It bronchodilates because the albuterol is in there. And so the only thing you can't fix is, which is longer term, is the swelling. So then when they get into the hospital setting, they're giving them a steroid to decrease the swelling. But it's like an 8-hour onset. Y'all remember Paul?
Mm-hmm.
Yeah. So Paul and I got into a discussion about steroids, and and I believe him because he's really smart. He goes, yeah, it takes about 8 hours for the steroid to take effect. Most of the time they give them what's called solumedrol. How would you spell that? Solumedrol. When you see this ending, it's usually a steroid, okay? Just for future pharmacology lessons, okay? But this is a steroid that's going to reduce the inflammation, but it has like an 8-hour onset. But he did say, Paul said, yeah, but there's some properties of solumedrol that take effect right away. And that's why you give the steroid right away if it's in your scope of practice, because you want those properties to help with the swelling. Until you get the swelling down, the bronchial is still going to be constricted. All right. So you do the ANA, the Atrovent, and the albuterol, and you can't do the solumedrol because that's ALS. This is ALS. So if you have someone really bad, you might request ALS transport, right? Intercept. Now, you do somewhere in here, 10 years positive, there we go. You might look at CPAP and then do both of these, okay? Depending on the condition of the patient.
Okay. When it's not severe, do you use a non-rebreather or nasal?
If they're not wheezing, there's little or no constriction, then it just depends on the patient. You know, if they're mouth breathing, they're still using some accessory muscles, you'll probably go ahead and give the breathing treatment. Okay? Even though you don't hear a wheeze, okay, doesn't mean there's not constriction. So go ahead and give the breathing treatment. Okay? Try to open them up a little bit. And then there's the picture. You've got a lot of mucus, swelling, okay? There's a lot of food in there, which is going to create not a good environment to oxygenate, right? So they break it down in a couple of things. A slow onset asthma, which is most of them, okay, over a few days. Respiratory tract infections, different things. The signs and symptoms are going to be the same, okay? These asthma patients, they can't get air in. When they start having an asthma attack, they feel like they can't get air in. I usually point at their chest and I say, where can you get air to? Because they can feel it. They're like, right here. Okay, so you're really constricted. Okay? Someone say, well, I can get air here. Right? So you point to that and say, where can you get the air into? And again, a good point though, even if they're not wheezing, there's still constriction there. So think of that. It's not a problem getting air in. It's like emphysema with air trapping. It's a problem getting air out. So their SpO2 is going to look what? Normal or abnormal?
Abnormal.
They get air in.
Oh no, they're getting
Oh, that'll be normal.
Yeah, their SpO2 look great up until they get critical. Then their SpO2 will start to drop. So their SpO2 be good. Just remember that it's just an aid. So don't really go off the SpO2 very much. So go off your signs and symptoms. They can't breathe. They feel really constricted, right? You're using accessory muscles, tripoded out, tracheal tugging, right? Nose flaring, Okay, so those are the things that you're going to see. You auscultate, you hear the wheezes, all right? A lot of times it doesn't take much constriction to cause the wheeze. The rapid onset, allergens, exercise, stress. Right? No. Exercise, stress. In this are a lot of the triggers. We're about to enter into the season where we have a lot of asthma attacks. If you worked on the ambulance right now, you'd be getting ready for asthma attacks in probably about a month. What takes place? Season change. What do we do when the season change? You may have already done it. We started a fire the other night. So.
Get cold?
What did you do when it gets cold? In your house?
Fires.
Yeah, and that's probably worse.
What?
Turn the heater on.
And
The dust mites.
Oh.
The gazillion dust mites are up in those vents. They blow out. They cause that immune response. Okay. Because people, the allergens, they start having people go into asthma attacks. Same way, you know, that nice period of time in the spring where you don't have to run your air conditioner. You guys don't know anything about it, but it's all related to money. You know, less you run your air conditioner, the better your electric bill is, right? But then summer hits in North Texas and you have to flip the air conditioner on. So you get the same sort of allergens. They store up in there, okay, plus the pollen and everything else. Stress, I've stopped counting really on the amount of, in it, I'm not picking on the young females, but that's the main population group it was, of the young females that I went on having an actual asthma attack. Respiratory distress, wheezing, full-blown sort of asthma deal, if that's what you want to call it, over the report cards. Go out to their house. It's almost automatic. 6, 7 o'clock in the evening, every 6 weeks. And they have this asthma attack over the parents are torquing down on them about their report cards. So stress-induced asthma as well. The rapid onset, because you have the very rapid constriction instead of sort of the slower constriction, and also the rapid influx of mucus, right, and swelling can lead to death. So it is very. There shouldn't be really anybody in the United States die from an acute asthma attack, but it has happened before. The first EMS agency that I worked for was a long time ago. Anyway, there was a Boy Scout camp out there, and this kid had asthma, so he was having an asthma attack. He brought his inhaler to the camp counselor, and says, "I'm having an asthma attack, and I mean a bad one." And so the short story of it is the counselor couldn't put together the nebulized treatment. She had the medicine, she had the machine, the nebulizer, couldn't figure out how to put it together. She panicked too much. And by the time the EMS crews got out there, the kid was way past. I mean, the intubatable type thing stuff. Then he ended up dying from the asthma attack. So it's easy to do, but you still have to stay pretty calm on doing it, right? I mean, anyhow, so do watch out. You may start having to use bag valve mask. You may have to go straight to the CPAP, right? But remember, you can give the albuterol treatment with the CPAP. So just like we said, good primary assessment. you know, make your decision on oxygenation, why you're setting up your breathing treatment. Just don't let the patient sit there without any treatment while you're setting up your breathing treatment, right? You know, you pick this patient up, they have this huge asthma attack or emphysema attack, this huge respiratory problem, and you're setting up the nebulized treatment, which doesn't take that long, right? But it does take a couple minutes. Go ahead and put them on some oxygen first, okay? That way it's good for the patient and it also looks really good on your documentation. Because without that, remember way back when we started this QA/QI, quality assurance, that there's always somebody reading over your reports and looking at your reports. So now if you don't put oxygen on the patient that needs it, you know, let's say they're in the tank, they're using accessory muscles and they're 88%, right? So you want to put a non-rebreather on them. And what happens in the QA/QI process is they look at the times, and all of a sudden now you have your patient going, you know, somewhere in between maybe 5 minutes or so without treatment. They're sitting there. Nobody's treating the patient. Does that make sense? So treat the patient right away. Give them oxygen. You can document the oxygen while you're setting up the treatment. Take the non-rebreather off of them. Put the nebulized mask on them. And you're continuously giving treatment. There's no break in treatment time. Okay? Okay. Next. Everybody good with asthma? Pretty straightforward. No questions? Pneumonia, even more straightforward, okay? Keep in mind, pneumonia is not necessarily for the elderly anymore, okay? Now, in test land, there's going to be some key words that you need to watch out for with patients with pneumonia. Typically, they're going to be older patients, okay? But there's little kids that have pneumonia all the time, all right? But don't let that trip you up. Pneumonia, like it says, infection, lower respiratory tract, that fluid starts to accumulate in the bronchioles. Just, do I have a picture? Yeah. Fluid, pus starts to accumulate here in the alveolus, gas exchange. There's a lot of pus right there, okay? The lung butter. So, is air going to diffuse through that?
Not really.
Nah. So this section right here, there's really no diffusion, no air exchange taking place. So you're going to see shortness of breath, right? Increased work of breathing. They're going to have to work to breathe. So there's fluid there all the time, but not a buildup like this. So when we look at it, like I said, it leads to poor gas exchange.
Thank you.
But what is the major thing that you're going to see in a patient with pneumonia?
Fever.
Right, fever. Yeah, most all the time these guys are going to have a fever. The chills is a fever. If they said, "Oh, I feel like I'm freezing," and they've got sort of the shakes to them, they probably have a temperature. Okay, so we don't. It's not common practice really to take a temperature on the ambulance, but if you think you feel the patient, they're hot to the touch, then they need to have their temperature taken, right? Most all the time, especially in test land, okay, the patient's going to have fever. So they're going to ask you, they're going to give you a scenario. The patient's wheezing, okay? That was where I was trying to go with that. Buffering moment there for a minute. What are you going to hear here with this when you auscultate that?
Crackles.
Yeah, you're going to hear crackles, maybe rails, depends on where that fluid is, that pus and that fluid is. So you're still going to hear rails and crackles. You may hear wheezes, too. This may create a wheeze, okay, in the bronchial. If the mucus and pus is in the bronchioles, then it's going to create that constriction. It's going to create a wheeze, okay. So, yeah, you might hear a wheeze there, all right? But most all the time and in real life, this patient's going to have fever, okay. So you're listening, okay, and you hear this crackles, you hear the rales and bronchi, right? Don't let that get you confused with CHF. How can you eliminate the CHF? No, like in a scenario, how you're trying to say, is this CHF or is this pneumonia?
Fever.
Huh?
The fever.
Fever.
Because it means there's an infection.
The patient's going to have fever. Every time that we have some sort of infection, right? Fever. The body spikes the temperature to try to kill the pathogen. That's the way we do it. Okay? So we don't have a fever. So if they look in, and they're going to look really sick, right? That good general first impression that you do, they're going to look sick. So you walk in, you go, you're having trouble breathing, you look sick. You know, have you been running a fever? Right? So, fever, chills, shortness of breath, nausea, really hard time with exertion. Okay? So, one thing I forgot to bring up the other day, on your OPQRST, right? What's the S stand for?
Severity.
Yeah, in pain, how do we do that?
1 to 10.
1 to 10. How are you going to do that with a respiratory problem?
How painful it is.
How hard
Yeah.
it is.
That is true. They may have chest pain, but the chest pain that they're having is related to their trouble breathing, okay? And in respiratory, typical respiratory chest pain increases with inspiration. So when they take a deep breath in, they're going to have an increase in pain. Remember, in MI, it's constant. But respiratory, they take a breath in, typically, okay, you have to rule out some other things, but typically, that's respiratory. But what's a better way to judge the severity in a respiratory emergency? Y'all remember that? Talk about it. I don't remember last
God, this time.
What's the best way to judge severity in a respiratory emergency? Then 1 to 10. Huh? Very good. How many words did they say before they take a breath? So me, I'm in no respiratory distress right now, correct? Okay? So I can probably talk a good 100 words before I have to take a breath. I'm used to it. Okay, but someone in respiratory distress will start, really, isn't it time for you guys to go to the library? Or is that today? Or did I just misread the email?
It is today. It is time.
We do have to
Okay. Good. Because I thought I was just getting old. Right? You see the difference in that's the better way to judge. Oh, this person, they're in such a high rest, they're having trouble breathing, they can only say 1 to 3 words without having to take another breath. When we get really bored, I think I told you guys last year about the ninja granny that she jumped
I
up.
don't think you told our class. But
Granny jumped up from the floor. I'll have to tell you the whole thing, but because you have to go. You already know. Maybe later. We'll get our milk and cookies, sit around and have story time. Okay. So, pneumonia, watch out for the fever. You can give them an albuterol treatment. That's acceptable. Okay. But a lot of times you would just sort of transport this patient.
Almost fell.
We would laugh. Supplement their oxygen, right? 94%. If lower than 94%, make sure they supplement. Respiratory problems. Say hello to the big guy. Respiratory distress, mouth breathing, use in accessory muscles, abdominal breathing, right? This can lead. I had a friend who I thought he was going to die in my presence. Had double. He got double pneumonia. Means he had pneumonia in both of his lungs. Okay. He was unresponsive. If I was on the ambulance, I would have intubated him. But and we took him to this third world hospital, and they almost killed him too. So, but anyway, it's quite a pneumonia can cause. It can be life-threatening. It causes quite a problem. You're not getting oxygenated, right? And we are aware of what happens with the lack of oxygen, right? Altered mental status, right? Organs start to shut down because they're not getting enough oxygen. What about pressure problems in respiratory emergencies? Blood pressure problems. You see any blood pressure problems? Hypotension? You see any hypotension? What scenario would lead you into hypotension?
Wait. That's a respiratory
Failing
problem?
in class.
Yeah.
Wait, what?
What? Not you, but the patient. What? Yeah. What would lead into a scenario where you would have hypotension, low blood pressure?
With a respiratory problem?
With a respiratory problem.
When it becomes severe. When it becomes severe.
Severe, yeah. But
Allergic reaction?
no, in respiratory. I know where you're going, but no, in this respiratory problem. Let's say in pneumonia.
Okay.
With pneumonia, when would you see hypotension? Starts with a bronchodilator would cause vasoconstriction, increase heart rate. That would actually bring the blood pressure up more than likely. Starts with an S. Septic, right? They can have sepsis, which is a big infection, correct? A life-threatening big infection. And they can get hypotension. Really rare. Most of the time you're going to see the blood pressure not affected, okay? You're going to see the heart rate increase because the respiratory rate is increased. You'll probably see that since they may be taking their meter dose inhaler, they're increasing heart rate as well, right? Plus they're stressed. They have a little anxiety built up there, right? Because they can't breathe. Okay. Picture this. Not that I would do this, okay? But let's say if I had a volunteer, I could do it, but I wouldn't do it. But if I had a volunteer come up and say, let's do it on can't get him up. Anyway, if I had a volunteer come up and I started choking that volunteer out, okay? I started closing that volunteer's airway off, and they couldn't get hardly any air in, right? What do you think would happen to their heart rate?
Yeah, it would increase.
Go through the roof, right? I can't get air in, okay? What about anxiety? Increase. Especially if you didn't know if I was going to let go, right? Your anxiety. anxiety would increase, fear would increase. So think about this. The patient can't breathe. All right? Good on pneumonia. Biggest thing is to remember the fever. Okay? Let's talk about the pulmonary embolism. Picture says 1,000 words. We have an embolism. An embolism is a clot, essentially, that moves from one place to another. So this could have started in the legs. It mentioned the deep vein thrombosis here in a minute. It may start in the legs and then travel. So an embolism travels. A thrombus is a clot that stays in place. Okay? But an embolism will break off and it will travel from one place to another place. So this big old fat embolism here was somewhere else. Maybe it was in the lower extremities, and then it broke off and it traveled in the bloodstream until it got into a vessel where it couldn't go any further. Okay? So in a pulmonary embolism, it got lodged in a pulmonary capillary bed, right? Which causes a huge VQ mismatch, ventilation perfusion mismatch. Right, so you have this clot here, and it's obstructed the pulmonary arteries. It could have ended up in the brain if it was smaller, and what would the patient have? A stroke, right? What about the heart? Not likely it would end up in a coronary artery, but if it ended up in a coronary vessel, what would the patient have?
Heart attack.
Heart attack, right. Now, one thing to keep in mind is, going the wrong way. This here, as it lodges in this pulmonary artery and causes this massive ventilation perfusion mismatch, this VQ mismatch, what happens with someone with a pulmonary embolism is they're getting plenty of air in. Okay, you have this patient that's sitting upright, bolt upright, trying to get air in. You're having a non-rebreather on them. You're blowing 1,000 liters per minute in, right? And the oxygen going in, it can't diffuse, okay? And that's where the VQ mismatch is. The disturbance between the ventilation, the air coming in, and the gas exchange at the alveolus, right? So no gas exchange can take place. Distal to this clot here, air can't get through. You guys understand the mismatch? So this patient's going to be bowled upright, okay? Oxygen is not going to really help them, okay, because the VQ mismatch. They're going to be very identifiable. Maybe they just traveled from overseas and they took a Benadryl and slept for 12 hours and didn't move like they tell them to get up and walk on the airplane, right? They might have just had surgery. That's probably the one that you're going to see on a test question. Post-surgical, like a hip replacement. All of a sudden they start having respiratory distress, severe respiratory distress, blah, 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 right, with signs and symptoms, okay? Post-surgical is one of them. Post-delivery, I picked up a lady that had an amniotic aneurysm, or amniotic embolism, okay? So some amniotic fluid somehow got in the vessels and clogged it up and caused an embolism there, and she ended up dying. Okay, the rest not necessarily from the respiratory, but what her problem was that she was having so much trouble oxygenating that she had a heart attack. She had a global MI. She was infarcted in every lead. So that was the official. So her cause of death was, global MI secondary to pulmonary embolism, was probably what they wrote on her death certificate. All right. So severe hypoxia. Okay. They're not constricted, right? So you're not going to necessarily hear abnormal breath sounds, but you're definitely going to be able to see this severe dyspnea, chest pain, anxiety. They can't breathe. They don't understand why they can't breathe. So that's the embolism, all right? Where this has traveled from somewhere, usually down south, and then has lodged in a pulmonary vessel. As best as I can recall, every patient that I've picked up with the pulmonary embolism was a fatality. I mean, we got them to the hospital alive, but they had an MI or they had something else that took them down. There's one at Dallas Regional, they took to the cath lab to try to remove the embolism because the weather was so bad they couldn't transfer the patient, so they took the patient to the cath lab. That was interesting. All right. But DVT, deep vein thrombosis. So this thrombosis ruptured, broke off, and traveled. Okay. So protect their airway, positive pressure ventilation, keep their stats up. All right. How would you assess their lower legs for a thrombosis? I'm saying that right. Or clot. How would you assess capillary refill? She left too early. Capillary refill, right? What else? Decreased blood supply. What else are you going to see?
Discoloration.
Some cyanosis maybe, discoloration. What's going to be the big telltale sign? Blood does what for us? Besides oxygen and all that, but huh?
Oh,
Heat keeps us warm. Okay. So what are you gonna when you do your physical assessment? What are you gonna feel?
cold legs.
Right. Cold extremity. Where the clot is, it's gonna be cold. The other extremity is gonna be what?
Warm.
Warm. Right. You can suspect maybe a clot there. Very good. Pulmonary edema we'll get to more when we talk about congestive heart failure, okay? But somebody with acute means quick onset. So this acute pulmonary edema could have been caused by an MI, right? This patient had a large surface area MI, a lot of area affected, and their heart is not contracting the same anymore, so they have a loss in contractility, and all of a sudden now they start getting a backup because the heart's not pumping, okay, the fluid. So you get the pulmonary edema from the heart not being able to pump the blood as efficiently as it used to before the MI or before the incident, okay? So now it starts collecting in the pulmonary capillaries in the alveolus, right? And like I said, it appears gas exchange. So we look at this. See, this is a normal. See how the gas exchange right here, there's nothing in the way, correct? Now keep in mind there is a fluid layer in between this alveolus and the capillary, okay? But it's a very, very thin layer of fluid. It's normal to be there, all right? This is not normal. See how this fluid now has built up a sort of a thicker wall, okay? And then eventually this fluid is going to get in the alveolus. So air's coming down here, and now there's a fluid in the alveolus, and it's not going to be able to diffuse through that. Luckily, we have billions of them, right? I mean, we have, I don't know, it's not billions, but it's like millions, okay? So we have a lot of them, so the fluid's not going to be everywhere. But what causes the fluid? Where does that come from?
CHF. It's backed up fluid.
Back up fluid, right? But where does it come from? I mean, how does it get I mean, we understand the heart's not contracting right, so it's going to back up because the heart's not pumping the fluid correctly. You can answer this this question in one word. That's a hint.
One word.
How does the fluid get there? Change. Pressure. Very good. So you have your alveolus, right? Your bronchial air's coming in here. You have your capillary here. You have a fluid level, a layer there, okay, already. What would that fluid be called? That's in between.
Oh, neat.
Starts with an I.
Interstitial fluid.
Interstitial fluid, okay, sort of. There's fluid in there, okay, floating around. So air come in. This is not a thick layer that's going to cause it not to diffuse. That's normal. And then the gas is going to normally diffuse across here. Let me draw this capillary a little bigger. I think that'll help you, okay? All right. So normally, let's say this, that you have a capillary that's like this. This is normal. This is blood in there, okay?
Okay.
So you have a capillary that's normal like this. Now if you get back up, now yeah, it's going to start in the big vessels and it's going to work its way back. But eventually, right, just like a traffic jam, eventually that traffic's going to get backed up off of the streets, right? Everybody's trying to bail off 635, and all of a sudden now all the little side streets are backed up because traffic's trying to get off there, right? Because of the backup. The road's not, something's wrong. There's where the road's not able to handle all the traffic, correct? So this vessel here, now it's backed up to the side roads. What's going to happen here with this vessel, with the fluid in here? It's going to increase, right? Because it's going to back up. The fluid's going to back up. So now we have, hypothetically, right? Now we have fluid here. This was the initial fluid line here. And now we have more fluid in that capillary. What have we done in the capillary?
We increase pressure.
Very good. We've increased the pressure in the capillary, right? Where's this fluid going to go? Because this fluid here is lower.
So it's going to go out of the capillary.
Very good. So we have a lower pressure in this fluid here, okay? A higher pressure in the capillary. So now, through what process?
Osmosis.
Osmosis. Now, this fluid here is going to go out into the interstitial, okay? Until it's equalized, right? If it doesn't equalize, where's it going to go?
Into the alveoli.
Right. So it'll just go into our little air sac. And now we have pulmonary edema. Now we can hear that. Okay? Does it make sense? It's all about pressure. It's all about this whole thing here. We studied it a little bit last year. It's called Capillary Dynamics, right? So about this fluid, intravascular fluid, interstitial fluid. You have pressures on both sides. You have pressure in that capillary. You have pressure on the outside of that capillary. You have a buildup of pressure inside that capillary. That fluid that's inside that capillary is going to be pushed through the membrane, okay, here, and then if it's not corrected, it's going to go into our air sacs, okay, our alveolus, okay. Everybody good with that? Sort of see the physiology behind this the pulmonary edema. We'll bring that back up again when we talk about CHF. But keep that in mind, okay, so we don't have to do the whole thing. All right, so we have crackles, rhonchi. We have Steve for that. If it's in the lower lobes, it's going to be crackles or rales. It's in the upper airways, larger airways, rhonchi. Cardiac symptoms, okay, anxiety. Why are they combative and confused?
Because they don't know why they can't breathe.
Well, no, they probably know why, but they have CHF, but why? Huh? Oxygen, hypoxia, right? Yeah, they're hypoxic. Okay, nothing against you. They're just hypoxic. This ARDS thing, I copied this down. Acute respiratory distress syndrome occurs when fluid builds up in tiny air sacs, the alveoli, right in your lungs. It keeps lungs from operating. So it sounds a lot like it is pulmonary edema, but it's also characterized by inflammation of the lungs. Okay, so they have ARDS. It's a syndrome. Anytime you hear something with a syndrome, they really don't know what causes it. Okay, but this CHF, these cardiac symptoms don't occur with ARDS. Okay, and then you can get ARDS with sepsis, inhalation problems, aspiration. I know this is small for you to read, but chemical fumes, severe pneumonia. You might hear the patient, they have ARDS. Okay, it is life-threatening. Okay, and then pancreatitis, blood transfusions, burns. So there's a lot of things people can get ARDS with. It's an acute problem that forces fluids into the lungs, into the airways. Okay, it's not necessarily cardiac related, right? It's a lot of CHF. I mean, it's not CHF, but it's a lot of fluid in the lungs that's not associated with the heart. This person could have a fine working machine heart, right, that has ARDS, but they're septic, or maybe they were in a house fire, or they had some sort of trauma, right, crushing injuries. So their heart's pumping away fine, but they get this inflammation. That's the ARDS, or they get the inflammation, which is the fluid. So if you hear the ARDS, that's what it is there. So you have someone with acute pulmonary edema. Always consider positive pressure ventilation. You might consider suctioning. This patient may have that edema coming out of their mouth, right? So remember the frothy pulmonary edema, the Starbucks, yeah. So they could have frothy pulmonary edema. CPAP may be beneficial, but you have to watch CPAP because it's going to hang on. You need to open up that airway, but they have a lot of fluid in there. So you can consider CPAP, oxygen. They have to sit upright. You lay this person down with CHF, it's going to feel like they're what? Yeah, they're going to feel like they're drowning because they have fluid all in their lungs. You lay them down, it's going to feel like they're drowning. So they're not going to lay flat. All right. This patient wants to sit either straight up or 45-degree angle. Watch for the jugular vein distension. Okay. Remember the picture the other day? The old man had the jugular vein distension. Okay. All right. And then transport, rapid transport. They need other medications that, as an EMT, that you can't administer to remove the fluid. Very good with CHF or pulmonary edema. We'll get back to it when we talk about CHF in a week or so. All right. Just a couple more. We're almost done. A spontaneous pneumothorax. We know what a pneumothorax is, right? It's the collapsed lung. The lungs collapsing because it's not really collapsing, but there's some damage to the lung, and that the air is leaking out of the lung into the pleural space. So this air that's coming in is leaking out into the pleural space. A spontaneous pneumothorax, a lot of times that is from a smoker. Smokers typically have, heavy smokers typically have spontaneous pneumothoraxes because, I don't know if you can see it here, but a ruptured bleb. Okay, let me draw a picture right quick of a bleb for you. So you have a normal, you have a bronchiole and you have some alveolus, right? Remember the sort of the grape sac? There's like a gazillion of them here, right? Air's coming down into there, right? So what happens with the smoker is, on the bleb, all that tar, that nicotine, that junk that's in that cigarette, okay, over time will melt these together, essentially. So they're just all become one big thick alveolus, right? Sort of melted together. And in a bleb, it ruptures, okay? And from that rupture, it causes damage to the lung, and then air will go out of the lung into the pleural space, right? And start collapsing that lung and pushing that lung over. Now, a spontaneous pneumothorax is different than a tension pneumothorax. It's not necessarily life-threatening, okay? But it has to be dealt with. You're going to have this patient that's short of breath. You're going to have decreased breath sounds on the affected side, right? They're going to have some chest pain, and so they're not really sure why. It really sort of mimics this upper respiratory thing, maybe an upper respiratory infection with the chest pain and everything, so they might just think they're coming down with something. But in this case, they have a spontaneous pneumothorax. Any pneumo will impair gas exchange, right? So what do? We transport. That's the only thing we can do. We listen for breath sounds. That's how we sort of pick it up. The big sign of the early sign of a pneumothorax is decreased or absent breath sounds. Okay, it's very rare that in a spontaneous pneumothorax you have tracheal deviation. That's a really late sign. It's the tracheal deviation. So we flip back here to the picture. As this collapses, it's going to push. Like this is the left lung, right? Yeah, the left lung. It's going to push this way. Once it pushes this way, it's going to deviate the trachea back this way. See, if it pushes this way, it pushes the trachea back this way. But it's a very late sign. Tracheal deviation is very late. Right? So you get maybe jugular vein distension, but the big one is decreased or absent breath sounds. Right? Increased work of breathing. They don't have to work really hard to breathe. Right? So one thing that is different in the treatment is CPAP is contraindicated. Okay, you can't. Why is CPAP contraindicated?
Because
it's going to make the pneumothorax worse.
Yeah, it will, big time. Because the pressure, your constant airway pressure, right? You're forcing air into that lung, and then you're just forcing it out back through the hole again, or the damage to the lung. Right? So like it says, if you have to do positive pressure ventilation, ease up on it a little bit, all right? But most of the time, the spontaneous pneumothorax, you're going to pick up off breath sounds, transport, oxygenate them, right? All the ones that I've seen they're not life-threatening. They only become life-threatening when the patient waits forever to get treatment. But usually their respiratory distress increases to the point where they can't wait too long. Okay. What about, this is very popular, again, different times of the year, especially report card time. Hyperventilation, right? You ever seen anybody hyperventilate? So they hyperventilate, their respiratory rate is, 40, 50, 60 times per minute, okay? They're blowing off a lot of CO2 because they're breathing so fast, right? Their hands start to cramp up, they have chest pain, all this. What do we need to do?
Calm them down.
Calm them down. Calm them down. Slow their breathing down. Take away the source of their anxiety, which is usually mom and dad. Okay? Take away that source. Calm them down. All this, all the cramping, all the chest pain, once you stop the hyperventilating, that all goes away. The CO2 gets back within normal 35 to 45, okay? And it will all go away. All the tingling and the cramps will go away because you've raised the CO2 level back up. If you're on an ALS ambulance and you have Untitled CO2 monitoring, you can see hyperventilation over a bronchospasm. See if you remember this. Untitled CO2 detection. Okay, if you have the patient on untitled CO2, a normal waveform looks like this. Okay. A bronchospasm, this is not a very good drawing, but that looks like Batman. But this, remember what we called that one? Right, shark tooths. They have little shark tooth formation. The waveform is going to be a shark tooth. This is for bronchospasms, okay? This is not a bronchospasm here. Nice inhalation, exhalation, right? Now, this is a slower rate, so if you have untitled CO2 and they're just hyperventilating, you're going to have a bunch of these together, right? And they're going to be these nice sort of square waveform, but they'll be all packed together because they're breathing 50 times a minute. So you're going to have a lot of them. But it's not a bronchospasm. They're not having an asthma attack or whatever. They're just having they're hyperventilating because they're having a normal waveform and not shark tubes. So, but more than likely you're not going to have that available. But that's just extra. So you'll know if you see that on untitled CO2. So slow the breathing down. Try to calm them down. Way back in the day, we used to make them breathe into a paper bag because they're rebreathing carbon dioxide. Okay. Closer, but still way back in the day, I'd put a non-rebreather on them and not put any oxygen in it. Maybe turn it to 2 liters per minute, right? And they rebreathe their carbon dioxide and sort of slow down. The reason we stopped doing all that is because somewhere in the world they were giving people heart attacks. They were causing MIs. So we actually used to carry brown paper bags on the ambulance just for that. But that was decades ago. We stopped doing that a long time ago. Now we're just trying to calm the patient down, get them out of that. This slide's pretty good, that emotionally charged situation, okay? Get them out of that situation. Calm their breathing down. Let them know that it's going to be okay, and all the things the cramps and all that is going to go away as soon as they slow their breathing down. And then if their sats do drop, you can put a non-rebreather on them, and that will help. Okay? Good? Any questions there? epiglottitis, these other things we'll speak of later, but they're childhood emergencies. Epiglottitis is life-threatening. Okay, that's inflammation of the epiglottis, right? So, yeah, we have a little picture here. Inflammation here. If the epiglottis completely swells, it blocks the passage to the airway off, right? It occludes the airway. So it's a big thing. You want to be very careful with the patient with epiglottitis. But that's we'll talk about next time. So if you have epiglottitis, pertussis, coughing, like a whooping cough, a big cough, okay, croup. A lot of these are childhood emergencies, okay, that you get into. Cystic fibrosis is a thing affecting the lungs, sort of hardening the lungs. A lot of pulmonary edema. One of my, not the first, I guess the first as a outside the hospital setting, but the first pediatric CPR I had was a patient with cystic fibrosis. The parents just panicked, called 911. Sad deal. They really should have had a DNR or something, but there wasn't at that place and time in their life to do that. So, let me keep going forward. We have a whole chapter over poison exposures and stuff, and bile and respiratory. We'll get all this next time.